This meeting is being recorded.
Good afternoon, everyone, and welcome. I'm Karen Kimsey, a partner of Speire Healthcare Strategies, a boutique healthcare consulting firm, former Medicaid director for Virginia's Medicaid program, and a key partner from the NORC MCO Learning Hub. The MCO NORC Learning Hub is committed to providing information on ways to address health equity and transform healthcare with a focus on MCOs, consumer groups, state Medicaid leaders, and other industry experts. The Hub is hosting a 6-part quarterly webinar series highlighting innovations in Medicaid, and this is the 6th in the series. The webinar series will include national experts discussing the latest trends, initiatives, programs, and findings on timely topics important to improving the Medicaid program and meeting the needs of beneficiaries. This webinar is focused on leveraging innovative and successful healthcare workforce strategies to fill existing and anticipated gaps. Before we get to the agenda and speakers for today, I wanted to note that all attendees will remain in listen-only mode. But please send us your questions using the Q&A box, and we'll get to as many as we can during the webinar. You can also find the slides for the presentation today on our Hub website. Today, we're joined by 3 physicians from Molina Healthcare who are pursuing local solutions to addressing some of the current provider workforce challenges they are facing within their states. We'll be hearing from Dr. Saeed Khan, Chief Medical Officer, Molina Healthcare of California. He will provide an overview of the California Primary Care Association Leadership Equity Program efforts to reduce health disparities in communities of color by enhancing the capacity of minority, emerging leaders, and C-suite executives. Dr. Khan is a physician executive with 2 decades of experience in coordinated managed care delivery systems. Since 2019, he has been the Chief Medical Officer of Molina Healthcare of California, which serves the needs of more than 500,000 members in both Southern and Northern California. Prior to this, he held leadership positions at Molina, as well as at several large medical groups in Southern California. Dr. Khan completed his undergraduate studies at Boston University, completed his medical school in Chicago, Illinois at Rush University, and did his internship at residency at Kaiser Permanente Medical Center in Santa Clara, California. He is board certified in internal medicine. In addition to his administrative responsibilities, Dr. Khan practices as a part-time hospitalist in Long Beach, California. Welcome, Dr. Khan. Dr. Jacinto Beard, who's a national dental director of Molina Healthcare, will highlight how the dental scholarship program with Ohio State University and with Case Western University is growing a diverse workforce and increasing care and access to care for underserved communities. Dr. Beard is a general practice dentist and owner of 2 offices in the Columbus community. As such, he takes tremendous pride in his 30+ years of service to the Central Ohio community. In this position, he provides dental services to private pay, traditional insurance, as well as Medicaid patients. Prior to opening his first private practice in the Columbus Northland community, Dr. Beard served as a dental director of primary healthcare in Erie, Pennsylvania, and he provided services to the Ohio Department of Corrections as a contracted dental provider. Welcome, Dr. Beard. Dr. David Valdez, who is our Chief Medical Officer from Molina Healthcare of Texas, will be discussing their partnership with Community Health Development Incorporated and the telehealth model established to provide mental and physical health services for students and teachers across consolidated independent school district schools. Dr. Valdez is the Chief Medical Officer of Molina Healthcare of Texas. As the CMO, he is responsible for high-risk case management and long-term services and support programs for people with disabilities and seniors who are Molina members, utilization management, management of large multi-state clinical and quality teams, as well as network development and serving as clinical liaison for physician and provider networks. Prior to his current role, Dr. Valdez served as senior medical director at AmeriGroup WellPoint. Previously, he spent over 10 years at Aetna as regional medical director, then CMO. He has over 25 years of experience in managed care and commercial, Medicare, and Medicaid health plans. Dr. Valdez has developed and implemented innovative approaches to accessing and accessing quality of care, and also addressing access itself and the challenges that are faced for Texas' most vulnerable Medicaid clients. So today's webinar will be a moderated discussion, and audience questions are welcome. As we stated earlier, just check that Q&A box. So please keep the questions coming, and we'll get to as many as we can. So as we get started, you may be aware that the Medicaid program now covers 1 in 3 Americans. That's 110 million people, up from 88 million in 2019, or a 25% increase. Medicaid enrollment surged in direct response to a federal mandate requiring continuous enrollment for the duration of the federal public health emergency. People really utilized Medicaid as a true access point during this crisis. This ensured no one would lose health coverage during the pandemic and helped stabilize a healthcare delivery system that was still reeling from the shock of COVID. As our country emerges from this pandemic, Medicaid programs continue to prioritize their most pressing issues. Medicaid eligibility determinations are certainly on the top of that list, but close behind it are workforce shortages, which are also cited as one of the biggest challenges facing states today. Workforce shortages are greatly amplified by the pandemic, which reduced the number of potential workers, increasing the demand for services. This especially had a significant impact on our Black and Brown communities. The American Rescue Plan Act, or ARPA, and the COVID Public Health Emergency authorities did give states new or temporary flexibility to funding to address these pandemic-related challenges. This included addressing workforce shortages, which states most frequently cited as the pandemic's primary impact across all healthcare delivery settings, and not just healthcare, especially for long-term services and supports, though. As the pandemic persisted, workforce shortages contributed to also not only accessing care, but in some cases contributed to provider closures. I know that did happen. In Virginia, we experienced over 400 providers closing during that time in Medicaid. States did address workforce shortages by leveraging 3 strategies. One was increasing home and community-based provider payment rates. Almost all states responded to the workforce crisis by increasing these rates. And they may have been supported temporarily through ARPA and public health emergency authorities, but more than half of these states plan to continue to keep these increases in place even after the authority and funding for the temporary supports expire. They've also been increasing caregiving flexibility by increasing self-directed family caregiving opportunities for folks who receive home and community-based services throughout the pandemic. All states offer at least one of these programs with options to people to self-direct their own care, and 48 states now allow legally responsible relatives and paid caregivers to serve during that capacity as paid caregivers for their loved ones, up from 36 in 2020. Several states have also been leveraging statewide minimum wage strategies. Most have a minimum wage that applies to all workers, but in 30 states, the minimum wage is higher than that of the federal requirement. And so that is a very important component that states are leveraging to help address and shore up their workforce needs. These changes, like I said, address but mainly on immediate needs, hopefully for the interim and long-term needs, but other creative strategies are also needed for the needs of this workforce. This is especially true for Medicaid-funded programs which utilize direct service care workers in many, many aspects of the program. So Medicaid programs have proven to be nimble through this process and respond quickly, but part of this is attributed to having steadfast partners, including managed care plans, to assist in implementing these changes quickly, and especially that happened in Virginia and many, many other states. And we're very, very grateful for that support in that way to reach the members so quickly. Managed care plans also have flexibility to develop what we call pilots or initiatives that can be implemented, like I said, very quickly and creatively address issues such as workforce shortages. So now I'm going to turn it over to our esteemed panel here to begin having the discussion about what examples are of these creative strategies that they have come up with and working in their own systems. And we're going to jump in and go around and have a discussion with each of you to share a brief overview of your current workforce initiatives and the goals that you're aiming to achieve with them. And we're going to start today with Dr. Khan. Dr. Khan, would you please go ahead and share with us your thoughts?
I'm on a call, yeah.
Great. Thanks, Karen, and good morning to you all who are on the West Coast and anyone who's east of the West Coast, good afternoon. Excited to be chatting with you today. My colleagues are going to talk, I believe, really in depth on the challenges on the provider side of the equation in the healthcare industry. I'm going to tie it a little bit into the not so direct provider side, and that's specifically on the leadership side. So if I can give a quick story, I think in my career, I have never had as much outreach from the provider community in terms of direction that was ever so changing as I did during the pandemic. Usually I enjoy conversations with the provider community as a health plan leader, but we were literally fielding calls every day, every hour with ever-changing recommendations from public health and CDC about how clinics had to change, new protocols that had to be put into place, and health plans were looked at as being sources of truth on the front line. So what I'm going to highlight is a program that focuses on healthcare leadership, particularly healthcare leadership in communities of color. It was evident through the pandemic that there were inequities, and those inequities were also being seen when it came to leadership organizations, particularly community health centers in California. California Primary Care Association recognized this and stood up a program in 2021 called the California Primary Care Association, I'll call them CPCA's Leadership and Equity Program. And it essentially aims to identify and find organizations that have individuals who are motivated to assume greater leadership roles within their organization. So these are typically middle-level management individuals who have a passion for what they do, and they represent the communities that they serve. They have the same lived experiences. They're traditionally people of color who work in those community health centers, and the goal is to get them into executive level roles within their organization or another organization within about 5 years or so. So that was the need that was identified. Molina happened to be at the right place at the right time because we were looking to help move this initiatives like this forward, and happened to cross paths with CPCA at the same time. And therefore we were able to participate. I serve on the advisory board for that organization. And so essentially it has two arms to the program, where one is identification of individuals who are going to be part of the cohort. They go through a year-long series of in-person and virtual sessions. But what's unique about this program is that it also requires that a leader from the organization, typically someone in an executive role or C-suite, also co-participate in that one-year journey, so that there's complete buy-in and kind of nothing comes back as a big shock with regard to what's being proposed. And so, I'm proud to be part of that organization, and they just concluded their first year's cohort. They had 19 individuals. There's clinical folks, so there's at least one doctor, some nurses, social workers, and a handful of non-clinical folk who went through year one. They had a wonderful experience. They just graduated in November with a culmination project, and the organization is now recruiting for year two. So I'm sure I'll be able to talk more about the program in detail, but that's the summary of the program for leadership and equity. Thank you, Karen.
Thank you very much, Dr. Khan. And next, we're going to hear from Dr. Beard.
Good afternoon, good morning, depending on where you live. First, thank you for asking me to be a part of this panel and important work in discussing current workforce issues. A couple of years ago, Molina Healthcare was doing research for our RFP in Ohio. It was noted that utilization of dental services in one particular county in Ohio by African American members was very low. This county was Cuyahoga County, or for those familiar with Ohio, it's the Cleveland metro area. This was a red flag because that county has a large population of African Americans and Blacks. And it also has a large number of providers in the area as well. So it was very concerning when we noticed that dental utilization in that area was very, very low by African Americans and Blacks. So the executive leadership asked my opinion on this and asked why the utilization would be low, especially when we have a great number of providers in the area, and you have a great number of African American folk living in that area as well. Well, being from Ohio and familiar with the Cleveland community, I shared with them African Americans and Blacks prefer seeking treatment from providers of their own culture. There is history behind this. I won't go into it today, but it's just a preference and a certain trust that they have. And so they seek out folk of their own culture, especially for their dental needs. I also knew that the majority of Black dentists who do practice today, they accept Medicaid. So the question is, why aren't there Medicaid providers there in the Cleveland area? I was also aware of just some of the demographics and the providers being from Ohio. I knew that the number of Black dentists practicing overall, just throughout the community, was dwindling. We were not educating as many African American dentists as were retiring. So long story short, to increase utilization in the area, you have to increase African American providers. That exposed another problem. There are fewer African Americans going into the profession. And those who do graduate are burdened with such high student debt, they're choosing not to accept Medicaid or locate in areas and with organizations that will not allow them to manage that debt. I proposed to Molina executive leadership, the best way to rectify this situation was to help educate African American dentists, Black dentists, who will go and practice in these areas. I submitted a proposal to Molina Cares Foundation, which is headed by Carolyn Ingram, to provide scholarships for African American students located in the 2 dental schools here in Ohio. Carolyn Ingram, as well as the planned president of Ohio, Amy Cole, were immediately on board with the idea and gave me the green light to set these scholarships, up in both schools. So today at Case Western Reserve College of Dentistry and the Ohio State University College of Dentistry, we have 8 Molina scholars being educated at the schools who have expressed a desire to locate and practice in the Cleveland area and accept Medicaid. It's early, but we're tracking the numbers. We want to see what type of impact it's going to have on the community and utilization. But if it's as successful as we anticipated, we plan to utilize this model to help cure provider shortages in other areas of the state as well. And hopefully it's a model that can be used nationally. Thank you.
Oh, thank you, Dr. Beard. Appreciate hearing about that. We're going to turn it over now to Dr. Valdez.
Yes, thank you, everyone, and great to be with you. Sorry, I think I've had a few power fluctuations here in the office, so I'll keep it quick. Basically, one of my other roles is I'm actually a provider, a Medicaid provider at a federally qualified health center in Uvalde, Texas. And as you very well may know, we had, the significant tragedy that happened here recently. As we started to understand what the FQHC's role could be in the community and expand the role of providers, we naturally thought about school-based clinics. With the support of Molina, we will be expanding and developing school-based clinics that the intent will be keep the children in school, especially if they don't have a condition that needs to be treated outside of the school, or try to reduce the inconvenience of families having to take their kids out of school to go access care when it can be accessed readily there at the school. So the Federally Qualified Health Center, Community Health Development, Inc. is working in conjunction with the Uvalde Consolidated Independent School District in order to have kind of a hub where we'll have a provider in one of the larger schools with telemedicine available in the other schools, kind of as nodes out to the additional schools to provide either in-person or mobile telemedicine in conjunction with the school nurses. What we want to do is to provide, testing, treatment that's on site. We want to improve screenings and increase health education. We want to supplement this with pharmacy access and pharmacy delivery, as well as transportation if needed. If our provider thinks that this student needs to be seen in our larger health center, we will be able to offer transportation with the parental support or approval of arranging that transportation to one of our health sites. We think that it'll be convenient, will improve timely diagnosis. And one of the things that we really have been working with, one of the state priorities, is to reduce avoidable emergency room visits and delayed diagnosis. These services will be offered to parents, students, teachers, as well as other school staff. So again, we want to keep the folks at school, if at all possible, provide them timely treatment and diagnosis. And treatment and diagnosis. The school district really likes this because we're providing convenience on site and supporting their school nurse. Also, their funding depends on attendance. And if kids are out of school, everybody kind of loses. So we really think that this program is going to really address multiple needs. And it'll be both for physical health as well as behavioral health. We will have the opportunity for medical students to come and round with our providers. So we're trying to offer access to medical education so that people might be interested in a practice like this, where it's a lot more proactive. And again, really also trying to give some of these kids in school some role models that they can see and have a tangible impact in hopefully their careers. Thank you.
Oh, thank you, Dr. Valdez, and thank you, gentlemen. I really appreciate that nice summary that you all are giving. It sounds like there's a lot of work underway with leadership growth, helping to develop professionals in the field to support members and meet them where they are, and also key and expanding services in key locations such as schools to also meet individuals and families where they are. And so we'll be moving into just a few extra questions to help provide clarity and information on the wonderful work that you're already doing. And I'll just start off with the first question, and then you can all each or one answer to the question as appropriate to your program. So first, let's ask, what types of information, data, or technology resources and or policies did you leverage to design and launch your initiative?
I can jump in a little bit. You know, policies as far as policies related to telemedicine that was really just, you know, exploded during the COVID pandemic, and the opportunities that we saw, especially in behavioral health, where many people felt comfortable accessing behavioral health care via telemedicine or remotely. You know, we know that there's an access issue in Medicaid in certain areas, especially in some of the rural areas. So understanding where those access issues were, and again, using technology to try to expand the access, you know, and selfishly on the provider side, you know, it's not uncommon for a federally qualified health center to have some issues with no-shows. So we have some capacity there, capacity that can be taken advantage of by something like a school-based clinic with remote access. So those were some of the things that we looked at. Of course, the communication and the partnership with the independent school district and what their needs were, especially after the tragedy, was critical that we provide a larger role in the community. And I've had a lot of support doing that.
Oh, great. I know absenteeism in appointments has always been an ongoing issue, with as much as 25% of appointments being missed. So that's a very critical area to address. Yeah.
Yes, absolutely.
Karen, I'll add from a leadership equity program perspective. While I'm not aware of key data that they use to develop the program, certainly health equity has been on the forefront in the last few years and is front of mind of any healthcare leader. I think that played a big role in looking at disparity data and understanding that things don't really move in healthcare organizations unless the leadership gets behind it. And in order for leadership to get behind it, they have to understand it, they have to feel it, and in many cases, they have to have lived it in prior lives. So community health centers across California, many of them heard voices that said, hey, you know, not all of our leadership fits that mold, and that we need to kind of open our eyes and start promoting from within and promoting individuals who can bring that voice of equity to the leadership forefront, particularly in Medi-Cal, kind of bringing it home. There is a significant change in the requirements from a policy perspective, that there is specific focus on communities, on looking at preventative care services for children and women of color. And those are written into requirements of contract. It's no longer a would like to have, it's a you must do this going forward with regard to quality measures. And so if you're going to design programs in your organization, whether it's at a health plan or at a healthcare center that focuses on individual populations, unless your leadership gets behind that, it's probably not going to be very successful. And so I see that as being kind of a big driver. That data and that requirement is a big driver for why we expect to see change.
Thank you, Dr. Khan.
And just to tack on at the tail end, again, I like to echo what Dr. Khan has said. It's very important for leadership to get on board, and I was just so excited, especially to see the Molina Foundation, really take a lead in saying, let's do this, let's get this done. And then when it comes to the schools, it's about leveraging opportunities. When approaching the schools, their response is, wow, we were looking to increase, African-American and Black enrollment in our schools. And we were just having, a tough time, in the recruitment and, getting people to get interested in dentistry as a career. It was, well known that, there is a significant expense to dentistry. And in the African-American communities and Black communities, that's a big turnoff. They do not want to be strapped, with a lot of debt. I would say any community, but again, when you're able to leverage these opportunities and be able to provide this kind of support, I think it's great. Where you bring two entities together, the schools and healthcare, both seeking to achieve the same goals. It's a win-win situation for everyone.
Exactly. And I know, gentlemen, you had touched on this just briefly, and if you'd like to expound upon it, can you describe the benefit of engaging local community partners or stakeholders? I know, Dr. Beard, you mentioned schools, and Dr. Valdez, you mentioned schools, but different types of schools. But can you describe what this means? Like when you engage these types of stakeholders, how does that mean? What the impact does that have in the design of your projects?
Well, I can go ahead and start in saying that both on the Molina side as well as the FQHC side, we really look at our constituents, and in Uvalde, we work closely with the school district as well as the board of directors for the FQHC, who are comprised, a majority of them are actually patients at the health center. We talk to the school nurses and we ask them, what do you need? How can we make your life easier? How can we support what you're trying to do? And really, we want to promote primary care instead of emergency room care. So we want to really keep the whole community productive and healthy. So we really saw this as a way to be a little bit more proactive, and again, try to get to what the kids and the teachers really need in order to have a productive day. And we really thought that this would be a way to give parents peace of mind, minimize disruption in their day, in their either their activities at home or at work. So we really thought that this improved had a lot of benefits for the entire community. And so that's kind of how we thought the engagement of the different stakeholders was so important.
Yeah, and for Molina, and our involvement with the schools, it's a mutual development of a diverse workforce. And, as a byproduct of, what we're doing, of course, we have 8 Molina scholars at the schools. That's being seen. That is being promoted at the university level throughout each of those schools. And now they are also looking, to further engage Molina Healthcare and myself in other projects as far as
Thank you. I think we may have a pause with Dr. Beard at the moment.
I think so.
So we will come back to him when he is able to rejoin us on the webinar. So thank you, gentlemen, for your thoughts related to that. And Dr. Khan, did you wish to have anything else on that piece, or you're good? Okay.
Well, I'm sorry. I'm good. Okay. Thank you, Karen.
Okay, thank you. Just double checking. All right, so as we move in this other component where we think about in relation, and I know this is in service for Medicaid beneficiaries, but can you describe to us, was there any involvement with Medicaid officials in these initiatives? And if so, and are there state officials even? And if so, could you describe what the involvement was?
I'll start in that we definitely closely aligned what we're trying to do with the state Medicaid goals. around, preventive care. This is an avenue to refer patients back to their PCPs, even if we're not their PCPs, back to their PCPs, to make sure that they're up to date on their screenings, their immunizations. If a student happens to have some chronic conditions, making sure that those are being managed carefully and appropriately. So again, health education. We want both students and parents to understand the importance of their healthcare access and taking advantage of their Medicaid benefits as well as their other health insurance benefits. So we found that very, very important in structuring the program and making sure all the outcomes were aligned with state as well as local health and public health goals. We really tried to incorporate the entire healthcare delivery system to understand how this might impact them, definitely in a positive way.
Great. Thank you.
I'll echo Dr. Valdez's comment that I believe that the Molina Care's support of this leadership equity program is directly in line with California Medicaid goals and policies with regard to preventative care services for certain populations, for, again, kind of highlighting African-American children and prenatal care as examples. The health plans, we are one level removed when it comes to kind of influencing and cajoling members into seeking preventative and primary care services. And so we have to be partnered and aligned with where the care is at. And so in supporting activities and initiatives like this, we feel that really opens up doors to foster better communications on what barriers are, even though we host, as a health plan, for example, we host member advisory meetings and community advisory meetings where we have folks from the community, both members and non-members who participate and give us feedback about what's working, what's not working, what they'd like to see, et cetera. It's also important to get that kind of feedback directly from organizations that provide the care. And so through efforts such as this, we believe that that's in line with state policy for Medicaid.
Great.
I'd like to add on a little bit to my comments. The Valdez community is located within kind of a little bit of a rural area, and definitely our health center serves a number of rural communities. Access has been an issue in rural communities. So again, this is another opportunity to get technology and healthcare access out into more rural communities. As we, some of these schools are not located actually within Uvalde, but some of them are in surrounding communities. Mm-hmm. So I think addressing the rural healthcare needs is critical. Both for primary care as well as with technology, providing access to specialty care is definitely something that we're working on.
That's great, thank you. And Dr. Beard, we're having a conversation right now about the connections with Medicaid officials or other state health officials as part of your initiatives, and what did that look like?
Thank you. I do not know why I got disconnected, but I'm happy to be back. It's ongoing, our connection with state officials. As our program develops, there has been talk or ask, potentially expanding. I heard my colleagues mention about rural, areas of their states. It's the same thing in Ohio. We have rural and Appalachian communities here in Ohio that are looking for providers. And again, it's about growing a diverse workforce and seeking out providers who will want to live and practice in those rural and Appalachian communities. It is well known, if you're from a certain community, you will want to go back and serve in that community. So, there's many ways to develop the program, the scholarship program that we've started to help address those other communities throughout the state that may be facing a workforce shortage for different reasons.
Thank you, Dr. Beard.
Mm-hmm.
I know if our Medicaid official in your states, I would be jumping for joy in terms of looking at, and in the sense of having a partner who's helping to look at addressing these strategies, especially as it applies to these particular aspects you're looking at. And it is clear in some of the conversations we're having right now that you're receiving positive feedback on member access, and also targeting communities that are harder to reach, and for a variety of reasons. And so it's very exciting to hear. So and now that we've talked about some of the impacts and that you're initially seeing related to your projects, and you're seeing some successes with it, are there any challenges in particular, in addition to successes, that you'd like to expound upon related to this? And especially, how would you build upon them as you move forward, especially addressing any challenges that you might have seen?
I'll go ahead and start. The schools have limited space, so we're trying to come in and provide more access, especially in the case of Uvalde, where we had students from the affected school going into other school campuses. So space is kind of critical, and not all of our schools are able to accommodate having a provider there. So we are looking at ways to bring mobile units, other ways to provide access, so that we don't disrupt the school and the work and the processes there, but again can be available conveniently to be able to offer, probably even more services than if we were trying to work out of the school nurses area. So we think of those as a challenge, but really kind of made us think about new opportunities to ways to bring the clinic really to them.
When it comes to challenges in my program, the biggest challenge is funding. And fortunately, Molina Cares has taken care of that. And so we don't have that challenge. But I also recognize there may be others on this call and other organizations on this call who want to try to model a similar program. And I would say that, we have to, be willing to reach out and look for funding sources in order to get programs like this. Loan repayment is needed. You want to say, how can I impact, providers? I mean, not just dentistry, medical. The cost of medical education is very expensive, but if you can offset some of that some way, if you, again, Molina does not have that challenge in that, we are supported, but if you're looking to stand up a program similar to this, or you have the capacity to provide the funding, this is a good way to invest in the workforce, a good way to invest in young people's future.
Excellent. Thank you.
I'd agree with what both Dr. Valdez and Dr. Beard have commented on. It comes down to the money. These programs are sustainable only if they've got financial backing to them. And so, fortunately, at least for us, for year one, there was good funding. A lot of the participants, for example, they've come back and have kind of talked to their leadership and said, hey, this was worthwhile in an effort to build future funding for additional participants. I think my perspective would be for all healthcare organizations, typically for clinicians, they usually have budgets for whether it's continuing medical education or the sort. But for non-clinicians, it's not always there. There's not always funds available to advance their careers, whether it's in leadership domains or otherwise. So that would be my perspective as a healthcare organization to consider having a fund, having a budget every year to invest in your people, to be able to kind of assume roles and take the opportunity, take advantage of opportunities like this, because at the end of the day, they cost money. There's not always funds available for that.
Thank you. Absolutely. And as we were talking about this related to funding, there was a question that did come from out in our audience. And I think this is a great point to segue into that question, which is, do you have any thoughts to retention strategies beyond pay that can be considered in retaining behaviorals and providers in the behavioral health scene?
Yeah, I'll go ahead and start it. I mean, I'm blessed in Uvalde, blessed to have a psychiatrist who is on staff at our health center, and recruiting and retention of other behavioral healthcare providers has been a little bit of a challenge. With telemedicine, there is a little bit more bandwidth for coverage. However, when we experienced the tragedy, we had a number of behavioral healthcare providers come immediately to our assistance from other communities, other health centers. And we started asking ourselves, why do they have such a good variety of behavioral health providers? How can we get there? And a lot of it came down to providing educational opportunities, either clinical supervision, so that we can kind of grow our own and promote the opportunity for local students to pursue behavioral health careers, as well as retain them by making their life more convenient, right? How do we minimize paperwork? Managed care organizations are really always trying to reduce hassle factor, prior authorization, claims issues, to keep our providers happy and especially to keep them in the Medicaid program. So I think all of those are opportunities where we can simplify their practice of healthcare, as well as giving them a steady stream of patients that they can see, because it's a missed opportunity for a patient as well as a provider if there's a missed appointment. Also in supporting their educational needs. Affiliations with medical schools, rotations of medical students. I think those are all strategies that we're implementing in our program.
Excellent, thank you. Okay, well, we'll move on to another question for you all. And just curious for you, what surprised you the most and was most noteworthy about your work and your initiatives? Something like a wow factor.
I don't know that I would say it doesn't surprise me, but the appreciation from the students and to hearing their stories, how it has, the receiving these scholarships, has opened up, other opportunities in their lives. Literally, they were saying, I was trying to work my way through school and pay for this and budget, because I knew that the debt would be significant. And now I can start, focus more on my studies and getting the work done. We were thinking about developing a workforce, but now we've also are, developing better students. They're not worried about the how am I going to cover this. Now they can focus on being the best clinician or and developing into the best clinician they could be. So you call it surprise, it just feels very rewarding. That would be my statement.
Great.
I would say for our program, it was the excitement of the healthcare center staff to be out there in the community, especially with kids. I mean, it's great to see them, in their element, and be able to provide this kind of outreach. It was just exciting to do something a little bit different, a little bit more innovative. And, we're going to be depending on their feedback, our staff's feedback, as well as the school's feedback on how this can be improved. This is going to be a constantly changing model according to the needs. And I think just very excited to be doing something new and more proactive.
Great. Dr. Khan?
Yeah, the thing I can think of is that was a little bit surprising was after the year one cohort completed their program, several of the participants came back and said, we want to form a quote, an alumni association, if you will, and participate in the recruitment of other individuals for subsequent years. I think that was a bit of a shock, and something that didn't go into the original program design was that we'd have folks who completed the curriculum who then wanted to participate in one, in the recruitment, but two, in subsequent development of the curriculum for future years. So that work is just underway. I think it was both surprising and exciting at the same time.
Wow, that's great. Thank you. And as we're talking about the wows and the surprises that we've seen and wonderful things that we're realizing in these initiatives, were there any shifts that you needed to make as you were moving forward? I think, Dr. Valdez, you mentioned one related to schools and some of the work you were doing, but to try and address a particular issue. And if those changes were made, how did, what type of change was it to adapt to your need?
I think just changing our whole approach on how we are becoming more mobile, and what all we're going to need to be successful there and effective, how to deploy our resources outside of the health center, and keep things was very, very important to make sure that it's cohesive, it's coordinated, and it's responsive to the needs. So I think those were kind of significant learnings and opportunities.
Thank you, Dr. Valdez. Are there any other initiatives or strategies or projects that you envision pursuing as a result of the current initiatives that you have in place?
Well, for us, what I'd like to see, expanding into is, not only do we have the scholarship in place, but there are shortages in other areas, and we have providers there, but we can't encourage them to accept Medicaid or become Molina members. I would like to, and we are in the talks, with the foundation as well, to expand into, further loan repayment. Many of those providers feel that is a huge barrier, to them feeling that they're able to, accept Medicaid in their communities. But if you were to, be able to provide some type of debt relief for loans, and these could be in targeted areas and different communities, and just, from a variety of providers, and say, hey, we have a need in this area, and we're willing to provide loan repayment a loan repayment program if you're willing to serve in these areas. So, we look forward to working on those initiatives.
Excellent. Thank you, Dr. Beard. And I'm hearing, we've heard a lot about loan repayment programs nationally, but very excited to see and hear where that can happen in our own communities as well.
Mm-hmm. For me, the whole challenges in workforce right now, and how to identify individuals early and motivate them to go into health careers, whatever health career that might be. I see that as us being out in the schools, we'll hopefully be able to identify and start mentoring programs, develop programs where we could say, if you want to become a professional, healthcare professional or healthcare worker of whatever type and stay in the community, you may have assistance with loan repayments or housing. Housing is a big challenge in recruiting healthcare professionals and keeping them. So I think it opens up the spectrum of ways that we can support the healthcare community providers. And I don't think it's just a problem in the rural areas. I think in many areas of the U.S., housing is an issue. So I think it's going to open our eyes as to what we need to do to really attract more people into healthcare.
Thank you, Dr. Valdez. And Dr. Khan, you had a quick little moment thought before.
Yeah, just a quick blurb on what Dr. Valdez says. I think there's huge opportunities for scalability of mentorship for leaders in healthcare, not only on the provider side, but on the health plan side is any opportunity to be able to bring that to the communities, because it's in many cases, it's a black box, and young individuals who want careers in healthcare, they may not know where to even start to look and who to ask questions of. So I think there's a golden opportunity, as busy as everybody is, to step into that type of role.
Oh, well, I wish to thank you, gentlemen, our esteemed colleagues. Thank you so much for providing us with a beautiful overview of the initiatives you have in place, whether it's growing our future leaders, having and bringing on more clinical care professionals, and increasing our services, all of this in our Black and Brown communities. Thank you for all that you do every day. And thank you to all of our listeners and viewers out there who are participating with us today on this panel and presentation on healthcare workforce strategies. Thank you to our health plan partners in Molina and everywhere for the creativity that you bring to our managed care programs. This concludes our presentation today and our webinar, and we look forward to seeing you again at the next webinar series. Take care.
Thank you.
Thank you.
Thank you.